So for the next topic, the topic is post-tuberculosis lung disease. And for that, I would request the chairpersons to invite Dr. Raja Dhar sir on stage.
We now have the honor of listening Dr. Raja Dhar, who is exceptionally prominent, internationally trained pulmonologist and critical care specialist based at Kolkata. At Calcutta Medical Research Institute, Dr. Dhar is currently serves as the director and head department of pulmonology and has also been associated with Fortis Hospital, Kolkata. So over to you, Dr. Dhar, for the presentation.
Thank you very much, sir. Respected chairperson, sir. Always a pleasure to be speaking at Dr. Pathak's meeting. He makes it a warm family affair, which adds to the attraction of coming and speaking in this meeting. So, as you know, I have got a flight to catch, and so has Dr. Suri. So I'll do this in 20 minutes. The remit of my talk is post-TB lung disease, and I hope it's of interest. I know we have a mixed population of audience today. We have doctors and we have non-doctors. So hopefully, I'll present things to you which are of interest to both categories. So I've called this beyond microbiological cure. तो हम सबको पता है कि हमारा जो नेशनल ट्यूबरक्लोसिस एलिमिनेशन प्रोग्राम है उसमें टीबी का क्योर जब बैक्टीरिया चली जाती है तब हम लोग बोलते हैं कि टीबी हैज़ बीन क्योर्ड इन एन इंडिविजुअल. However, for a lot of people, it is the start of a new disease. It is the start of a lot of symptoms and morbidity, and in some cases, mortality. So this is what we are going to do over the next, not 30 minutes, but 20 minutes. We'll talk about the burden of post-TB lung disease. We will talk about post-TB bronchiectasis, which is my area of research interest. And I'll show you some Indian and some global data on this. We'll talk about what's described as TOPD, or TB-associated obstructive pulmonary disease. And then we'll talk about conditions beyond bronchiectasis and TB-associated obstructive pulmonary disease, like lung fibrosis, pulmonary vascular disease, and aspergillus infection of the lung in the way of chronic pulmonary aspergillosis. And then a couple of slides about the future. So all of you know that TB in India still remains a killer. If you look at the number of cases worldwide, it's 10.8 million. And out of that, an estimated 2.8 million come from India. So 1 out of 4 cases of TB in the world is from India. We are number 1 with the highest incidence globally. And of all of these patients, the 2.8 million every year, you have 50% who are left behind with some form of chronic lung damage which gives them symptoms. So 1 out of 2 patients who have microbiological cure from TB will have symptoms in the post-TB period. The problem is that we talk about TB a lot. It's a part of the biggest of government programs in the country. However, importantly, we don't talk about the after effects of TB to any significant extent. TB treatment success continues to rise globally, and that's something to celebrate for all of us. We celebrate the fact that TB cure is something that we have managed to achieve. However, like we said, microbiological cure does not equate to a healthy lung, and permanent damage of the lung, be that damage of the breathing passage, the airway, be it damage of the lung parenchyma, or be it damage of the vasculature, always remains and gets worse even in the post-TB period. So the ravage of inflammation in the lung continues way beyond the time TB is microbiologically cured, and hence exercises in case finding in the post-TB period is of utmost importance. So like I have said, cure is not the end of the story. For a lot of people, it's the beginning of their illness. And the reason is threefold, and I want you to remember these 3 terminologies. It's important to remember them. So one is Mycobacterium tuberculosis, the bug causing airway and parenchymal destruction. The second is the immune mechanism of the host, the person who's been treated with TB. The host response results in a granulomatous inflammation, fibrosis in the lung, and scarring that happens during the course of treatment and after treatment is completed. And that injury is multi-compartment, we have said. So the large airways, the small airways, the lung parenchyma, and the blood vessels all undergo continued damage even after TB has been cured under these umbrella. So the term post-TB lung disease encompasses not one disease, but multiple diseases. There's bronchiectasis, that's the commonest. Then you have airflow obstruction, which is the TB-associated COPD or TB-associated obstructive pulmonary disease, what's called TOPD. Then you have the scarring of the lung resulting in pulmonary fibrosis, which is different to the interstitial lung disease that we all speak about. Then you have chronic pulmonary aspergillosis, which is the fungal mimic in these individuals. You have pulmonary hypertension, which is not as uncommon as we think. It's rarer than the other diseases, but still happens significantly. And the end result of all of this is chronic respiratory failure, which is end-stage lung disease, which happens in about 10% of patients with post-TB lung disease. So I won't read through this again for the sake of time, but remember this cascade. TB infection resulting in increased inflammation, resulting in structural damage in a multi-compartment scenario. You have fibrosis and traction and the chronic sequelae. If you think about post-TB bronchiectasis, I said that's my area of research interest. You have the structural damage resulting in dilated airways. The dilated airways have pools of secretion within it. It grows bugs like Pseudomonas aeruginosa and Klebsiella pneumoniae. Chronic infection, more inflammation, more airway destruction. All of this results in an accelerated decline of lung function in these individuals. So I want you to remember these three. You can forget the others. The three phases of post-TB lung disease that I'm going to speak about today. One is post-TB bronchiectasis, the other is the obstructive pulmonary disease, and the chronic pulmonary aspergillosis. And look at the case load. Bronchiectasis, the largest cause of bronchiectasis in Indian population is post-TB bronchiectasis, which came out of our study, the EMBARK registry. Then you have TOPD, 90% of post-TB patients, that's again our study from the Respiratory Research Network, 90% of post-TB patients will show some spirometric abnormality, 50% of them fit the criteria of COPD, and 30% of these patients have what's called PRISM, which is preserved spirometry but impaired, so preserved lung function but impaired spirometry. Chronic pulmonary aspergillosis, look at the numbers, 1.5 million cases in India. 22% of cavitary post-TB patients have chronic pulmonary aspergillosis. So huge numbers, the load is massive. So let's briefly talk about post-TB bronchiectasis. So this is data that I'm presenting to you, which were published very recently. Data between January 2015 to April 2022. So over 7 years from 27 countries in Europe, plus Israel, India, Pakistan and Kyrgyzstan, patients with confirmed bronchiectasis on HRCT, about 19,500 patients. Out of this cohort, 12% had a history of TB, and the physician thought that 8% of these had post-TB bronchiectasis. So 12% in a cohort of 30,000 is a huge morbidity. That's a huge number that we are talking about. What's the global variation? Expectedly, if you look at Asia, about 40% of bronchiectasis in Asia is post-TB bronchiectasis. And then Eastern Europe, 15%. And then if you go to the UK, the smallest number of 6.3%. So our population, the population that we subserve to, all of you look at, has the largest numbers of post-TB bronchiectasis. So India, 35% of the total number of bronchiectatics are post-TB bronchiectasis. The mean age of presentation is 55 years. The males exceed the number of females, and cystic pattern of bronchiectasis in the upper lobes is the most prominent. So again, I want you to remember this bit. 35% of total bronchiectasis is post-TB. The presenting age is young, much younger than the global population, 55 years. More men as compared to women, and upper lobar disease, cystic disease is the classical in these individuals. If you compare the post-TB bronchiectasis phenotype with the non-post-TB bronchiectasis phenotype, there's a couple of things that stand out. First, the post-TB bronchiectasis population is a little older. They do not have much of an overlap with asthma. They have worst lung function out of all causes of bronchiectasis. So patients with post-TB bronchiectasis have the worst lung function out of all etiologies of bronchiectasis. Upper lobar disease and cystic disease is the common phenotype in these patients with post-TB bronchiectasis, and it's important to remember these differences. What about outcomes? So if you look at outcomes, the exacerbation frequency of patients resulting in hospitalization is far greater in the post-TB cohort as compared to the non-post-TB cohort. The mortality risk when corrected for other factors, however, remains equal. However, important to remember, hospitalization frequency and exacerbation frequency is greater in post-TB bronchiectasis as compared to other causes of bronchiectasis. So what do you do for these individuals? You do more vigorous airway clearance. It's important to move secretions, and hence airway clearance is of utmost importance. Trying to identify the Pseudomonas and Klebsiella early is important. Some of these patients who are post-TB, interestingly, go on to develop non-TB NTM infections, and NTM infections in post-TB lung is something we need to exclude. You had a workshop today, I know, on pulmonary rehabilitation. Post-TB lung disease is one very important area where we have not targeted enough of pulmonary rehabilitation, and that's an important area to look at. And exacerbation management, we said post-TB patients have more exacerbations, and hence to try and manage exacerbations with these individuals by identifying them early is important. So my key messages for post-TB bronchiectasis: it's a major global burden, it's a distinct recognizable phenotype, severe exacerbations define the risk, and mortality independently is not increased, however hospitalization and exacerbations are. So major global burden, 12% of the total number of bronchiectasis throughout the world. It's a disease within the bronchiectasis area which you can recognize separately: older age, upper lobe cystic disease, the worst lung function, more of Pseudomonas, severe exacerbations define the risk, and mortality does not seem to increase. That brings me to the second group, which is post-TB airways disease. We've called this TOPD. Again, 10% is the global prevalence of COPD throughout the world. 3 to 11%, greater numbers in India, have non-smoking or never smoking COPD. The total number of deaths from COPD is 3 million. 3 million, that's a massive number. And 35.5% of Indian patients, we said, have post-TB bronchiectasis. A lot of these patients, while we have not looked at it specifically, will also have obstructive airways disease. Hence, it's important to understand that when you think about COPD, think about the post-TB population. They need follow-up, they need spirometry to find out whether these individuals have post-TB obstructive airways disease or not. This is the study that I'll very briefly quote. So about 860 patients from 25 centers in India. The age group is 18 to 65 years, and the criteria was they should have completed anti-tubercular drugs and become sputum negative. So those were the inclusion criteria. Patients from throughout India, multicentric observational study, and we looked at questionnaires to look at demographics, treatment, TB history, etc., spirometry, which was pre and post bronchodilator, and scoring of the chest X-ray. So what did we find? We found similar to bronchiectasis, the mean age was somewhere around 52 years with a significant male predominance. 20% of patients were smokers. The inclusion criteria mandated that the number of years of smoking should be less than 10. So 20% smokers, 10% biomass exposure. The TB duration after which they presented was about 16.5 years. And these patients, a large majority, had negative AFP when the patients got recruited, or we could not find the microbiology report for these patients. This is the important slide everyone needs to remember. So 50% of patients had COPD by gold criteria. 30% of patients had abnormal spirometry, which could not be classified as asthma or COPD. Only 8%, a small number, had asthma. And only 10%, 11% of patients had normal spirometry. So COPD 50%, PRISM 30%, 8% asthma, and 11% of patients had normal spirometry. If you look at symptom burden, there's huge symptom burden. About 65% of patients had a CAT score of more than 10 and an MRC of more than 2, which basically signifies that there was a lot of symptom burden. 60% reported one exacerbation or more in the past year. About 20% had post-bronchodilator reversibility. And this is the important and interesting part. The greater the fibrosis on the chest X-ray, the greater the incidence of obstructive pulmonary disease. So looking at the post-TB chest X-ray, you could predict whether the patient had a greater chance of obstructive pulmonary disease. So important numbers to remember. More than 65% had a lot of symptoms. About 60% had one or more exacerbation in the past year. 20%, 1 out of 5, had bronchodilator reversibility, and the odds ratio for fibrosis leading to obstruction was significant in this population of patients. So TOPD, like post-TB bronchiectasis, is a distinct phenotype in the arena of non-smoking COPD. They have distinctive radiology, which is scarring and fibrosis in the upper lobes of the lung. These patients have a less classic obstructive spirometry. They have more exacerbations similar to the bronchiectasis population. Here, it's not the lung parenchyma, it's the small airways and the blood vessels which get affected. So whenever you see TOPD, there would be a significant element of pulmonary hypertension along with having small airways affection. And important to remember, inhaled corticosteroids should be avoided in these patients. We have good data from South Africa and from India which shows that using inhaled corticosteroids in patients who have had TB in the past and airways obstruction results in a recrudescence, a relapse of TB in this population of patients. The last 2 or 3 minutes, I'll speak about beyond bronchiectasis and COPD. So post-TB fibrosis and vascular disease are significant numbers. I showed you some numbers a little while ago. Upper lobe disease, traction bronchiectasis with a restrictive spirometry, and pulmonary vascular disease is due to destruction of the parenchyma and the pulmonary arteries, which results in chronic hypoxia, which results in more pulmonary vasoconstriction and more of pulmonary hypertension. And hence, these patients present with chronic respiratory failure. The important one is this one, and I want you to remember this one message even if you forget the rest of my talk. So if you have a patient who we have treated for TB, the patient goes home, you need to follow them up and see whether they have persistent symptoms. If these patients have cavitary disease, if they continue to cough, if they continue to produce sputum, if they have hemoptysis, the chances are that these patients have chronic pulmonary aspergillosis rather than having a relapse of their TB. And that's a very important message I want you to take through. There's been studies that has come out from Ritesh Agarwal's group in PGI Chandigarh, which have shown that 20%, 1 out of 5 patients who have post-TB cavitation will go on to develop chronic pulmonary aspergillosis. And the numbers, like we said, the mortality from this disease is massive. So one important thing, A, once you complete TB treatment, follow these patients up. B, if they have persistent symptoms, screen them for CPA, for chronic pulmonary aspergillosis, because 1 out of 5 chances, that's the disease that these individuals might have. So where do we go from here? So we need to go towards an integrated post-TB pulmonary care, and that needs to come within the ambit of the government TB program. It doesn't finish when TB treatment is complete. It should go on for long term, at least for a year beyond the TB cure date. So end of treatment, patients need a chest X-ray and a spirometry. 3 months post-treatment need a repeat spirometry. If there are symptoms on a symptom questionnaire, HRCT is mandatory. 6 months post-treatment, you repeat the tests if they're symptomatic, again an HRCT. If they have persistent symptoms, look for aspergillus, and then they should have an annual review for 3 years. So those in my book are the research priorities in PTLD. Mechanism and endotypes. Why do some people with post-TB develop bronchiectasis whereas others don't? Pseudomonas biology. Why is there more aggressive disease in patients who are post-TB with aspergillus? Targeted therapy trials using inhaled antibiotics in groups of patients with post-TB. screening routinely for chronic pulmonary aspergillosis in the post-TB period. Longitudinal Indian cohorts like EMBARK are important, and like I said, it needs to be a government policy, hence health economy and policy research is important. So those are my concluding messages. Post-TB lung disease is common, much more common than you know. 1 out of 2 patients would have it when they've been cured with TB. Post-TB bronchiectasis is a distinct phenotype where there's a higher hospitalization risk. TOPD affects patients treated for post-TB and is related to fibrosis in the upper lobe, and they are more exacerbation prone even though they might have preserved lung function. Chronic pulmonary aspergillosis is common. It's a dangerous mimic of TB relapse. And last but not the least, a simple structured post-TB follow-up is important, and we need to do it at 3 months, 6 months, and then annually, depending on the intensity of symptoms in these individuals. Thank you very much for listening.
Doctor, wonderful presentation, but lot of questions for the internist and general physician, because you haven't said anything for the prevention. What should government do for prevention? The one question. The second, like we have vaccines for those patients who develop other diseases, antiviral vaccines for the also Diplococcus pneumoniae. Do we have any such vaccines against aspergillosis or Pseudomonas? You said higher incidence of Pseudomonas aeruginosa.
Sure. So wonderful question, sir. So the first question you had was, is there something that will help you to prevent post-TB lung disease? So unfortunately there isn't. However, what you can do is in cavitary disease, in the post-TB follow-up period, you can have greater surveillance of these patients and try and diagnose post-TB lung disease early. So that's one top tip in trying to diagnose these people early. You spoke about vaccination, very important point. I did not mention it, I should have. So these people should be vaccinated the same as you do in any other chronic lung disease. For pneumococcus, you should vaccinate them for influenza, you should give them shingles vaccine, the RSV vaccine when it comes. All of them are very good practices, and thank you very much for pointing it out for me. You spoke about Pseudomonas. So importantly, there are good drugs which are coming in biologic therapy to prevent Pseudomonas in individuals. We'll have it in 5 years' time. It's still on the anvil, but we'll hear about it more as we go along.
Thank you.
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.